Do you notice it happening most commonly on one foot or the other?
No.
Okay.
Usually one foot is worse than the other, but I wouldn't
Is
say
there
is
there a theme on that?
No.
Okay.
No. Not that I've seen.
Okay. So just for context, so I studied, like, my bachelor's degree is in journalism. So when I was trying to learn this stuff, I used a PT clinic in Nebraska called the Postural Restoration Institute. I highly recommend it. I mean, they are remarkable. The science that I've never found anybody who understands the human body and can explain how the body works better than them.
Amazing.
I'm open to anybody else, but this is the best I've found. And they look at the anatomy of the body, right?
Okay.
And so they're looking at the liver being on one side, they're looking at the heart being on the other side. It's on opposite sides of the diaphragm. The crural attachment of the diaphragm on the right is bigger than the left. The leaflet of the diaphragm on the right is bigger, more muscular on the right, so on and so forth. And all of this, 3 lobes of lung on the right, 2 on the left, right-left brain, it's a propensity to push everybody to the right side.
Okay.
So think Statue of David, the famous David statue, right?
Yes.
And he's in what they call the left AIC pattern, which is just the body is shifted over to the right side.
Okay.
And so in that, if you look at the Statue of David, maybe depending on how technically savvy I am, I'll put a picture up for the clip. But so you'll see the outer edge of the right foot is more prominent. So they're rolled out on the right.
Okay.
And then on the left, you start to see that pronation. So the foot flattening.
Okay.
Typically, I'll see the calcaneus rolling inwards on the left. That's where I'm kind of looking to judge that. And depending on how far along they are in this pattern, assuming you're subscribing to this belief, depending on how far you are into this pattern, you would expect to see the left come down first and then the right come down second.
Okay.
Now you could see them both. You could see them both down, and I see that we see super flat, and then we see couples that are like flattening. But I do see this happen frequently. I'll stop there. Do you have a take on that?
I mean, in my practice, I haven't seen one foot more than the other.
Sure. So I'm definitely looking at it through a lens.
Right.
When I'm seeing people, like, there's like an expectation that, like, okay, like I based on the science and the theory, I should see more left than right. I don't know that I see that either in my own, like, if I'm being honest. And
you're saying like static or when
if I just have both.
Okay.
And so like you see commonalities in when they're kind of going through a gait analysis, walking down and back. But if they're just like standing and I'm doing 360 and literally just an eye test for me, I don't know that I really see a difference in one side or the other, but I'm using this lens as like what I expect to have happened to have gotten them here. So the thought is to pull them out of that right side dominance is you need left hamstrings and you need right glutes.
Okay.
So like I mentioned earlier, the signals, the proprioceptive, they call them reference centers, is left hamstring would be left heel.
Okay.
And then right glute is right big toe, right arch.
So you're putting in a heel cup in the left.
I'll put a heel cup in the left. Now, this isn't always, because like if they've gone down the pathway, you might need to peel that back. Like I've had probably the most success with heel cup right.
Interesting.
Because the theory is they go left AIC first, they go propensity to the right, and then they become what they call a PEC, where they've just kind of lost the gait mechanic on both sides.
What is PEC?
PEC, the names are they make it so hard. I apologize if the people are watching this, great people, but the names, they don't do a great job in making the names understandable. Like even the left AIC is a right side dominant. And so the PEC means that you've lost biomechanics, quality gait mechanics on both the left stance and the right side. It's like an anterior pelvic tilt on both sides, bilateral rib flare. It's a little bit more complex than that, but roughly that's what that's their theory.
Interesting.
And so I'm always looking at it through that lens of what does this person need? And like as I work my way up the chain, if I'm seeing like left AIC test responses, I'm assuming that at the foot level, that's like the undertone.
Okay.
So the by the book deal is left heel cup, right arch, and we're trying to get them to move themselves back to the right. I guess the question for you is obviously like, what's the hot take? What's your initial take on, does that make any sense to you? Any thoughts, any rebuttals? But also, do those reference centers check out? Like does putting a right arch, does that facilitate push off? Does that facilitate right glute? What's your take on an arch insert? What do you got?
What do you mean by arch insert?
Yeah. So, and truthfully, like what I do, I call it like dummy footwork, right? So like, I'm like, I don't really know what I'm doing here, but I understand a little bit of this stuff. So I'm just going to take like this felt pad, stick it to the bottom of your foot, put you in a shoe and see if it makes a dramatic difference. If they come out and they're like, it feels weird, but nothing really, then I'm not even bothering with it. If they go, if I put it in and there's like a profound effect, then I'll dive a little bit deeper. And if it truly is, like if the tests change and everything, that's when I'll recommend custom orthotics, because I'm like, clearly the foot is a major driver for you. Okay. And now I want to, like, I think that you should have something in there because it's such a major like lead domino in somebody's biomechanics.
So here's my question.
Yeah.
If you do a left heel cup and a right arch, and then you recommend orthotics, what is the orthotic?
So the orthotic,
confused.
The orthotics that I've used in the past is there's a guy who subscribes to this science. And so he'll give orthotics that are different on both sides.
But the arch, technically, how is the arch different?
Well, so,
is it a higher arch on one side versus
yeah, that's what we'll see. And if we're looking at statically, and again, like I will say that it's entirely possible that I'm coming at it from a confirmation bias perspective when I'm looking at somebody's feet. And it could also be that like the reason that I've had profound effects with some people is because they're just like, you throw a clutch right 2 times a day, right? And so all of that is entirely possible. But I'm just like when I'm looking at feet, like that is what I'm looking for. Okay. And then if in certain cases I am putting something in there and then getting this response, I mean, from somebody who studied it, I want to know if it holds any weight, or are you like, no, that's ridiculous?
So when I make orthotics,
and you feel free to say it's ridiculous. Like I'm genuinely trying to get better at this.
I'm not going to say it's ridiculous because I don't know that I fully understand it completely what you're talking about. But when I make orthotics for patients, obviously we do custom orthotics. Right. And so it is molded to their foot. So it is possible that one arch would be higher than the other. Sure. And therefore the orthotic on that side, the arch is higher.
Right.
As far as the heel goes, I never make the heels different. Okay. Unless someone has like on one side a ton of eversion versus the other. Usually if they're everted on the left, they're everted on the right to some degree because they have bilateral flat feet. Sure. So I don't change the inversion, which is the opposite of eversion, in the orthotic. Okay. Like more on one side than the other. And I always do a deep heel cup because I just generally think for most people, again, with the proprioception, it's great for them. Right. The arch thing is very interesting to me because maybe we are inadvertently doing it by custom making the orthotic. For sure. So we might be doing that and just, I didn't actually think I was doing it. Yeah. The other thing we do a lot of times is a metatarsal pad, which technically hits kind of where you're talking about. Right. Less obviously in the medial arch, more directly under kind of the arch area of the foot. And so that could also be
So what do you when you're putting those things in, are you you're trying to restore the gait mechanic, that fluid gait action? What are you trying to
for a metatarsal pad? No.
For all of it. So like when you're putting anything in the foot. Yeah. What's your barometer of success?
Yeah. So and the best way to like see if an orthotic is really working is have someone stand on the orthotic and you should see their heel come back to rectus. Okay. So it should be correcting that deformity. Okay. And like I said, if the heel is in good alignment, then the rest of the foot is.
How do you measure that? You just eyeball it?
Yeah, you can literally see someone's heel will be like this when they're not in the orthotic. And if you made a good one, it will go like this. Yeah. Which is great. Yeah. And a lot of people, it doesn't fully correct it. Yeah. But a lot of shoes also correct it to some amount. So you don't want to overcorrect people.